to all of them. Oh, let me do that. Okay. Namaste, good morning to all of you guys. Thanks for joining us with another session of Jivanta. Jivanta means Jivan. Jivan is your life. That's the English meaning of the Jivan is life. So it's we have one life, and then we are living this life, going round and round. So taking care of our health, our wealth, and our loved ones. So Jivanta seminar is it's a kind of one support helping you to grow you, and we already introduced I Am series since 2022, and we are working on that series every month. And today we're going to talk about health, and like so many things are going on. Before I go to the introduction, I want to do a little prayer because I believe in prayers. It's like a sound chanting, so it goes around everybody, and I believe in that. And I'll explain to you the meaning of that prayer. So let's do that. Om Sehna Bhavatu Sehno Bhunaktu Sehviryam Karvavahe Tejasvinat Vastu Ma Vidhi Vishadvahe. Again, thank you. The meaning of the prayer is whatever we are doing together, God protect us while we are doing that together, and merge our energy together so we can make one. That we are talking about. Like I go to DAYC Yoga Center, and Baiji always do spiritual courses there, and we learn a lot about so many good things. So there, the DAYC is a spiritual center. So sometimes people ask me, okay, which gods they believe in it? Do you have a mandir there? What you guys do there? It's a yoga, meditation, and what else? What do you mean by spiritual courses? Like, what is do you do kirtan? The Indian people ask me, do you guys do the kirtan? So I learned from Baiji, like, that it's kind of support, emotional support to you. It doesn't matter which God you believe in. You can be Muslim, you can be Hindu, you can be Christian. But the one thing is, it's kind of mountain. It's a mountain, and you have to reach there. And there are so many ways to go in. Like you can go from Pomona side, or you can go with a different side, like whenever you go to hiking, you do that. So those are the paths to go up. And then everybody need to go. They want to go up, and then in peace. So the religious or wherever you go, what they are doing, what they are teaching you, they are telling you to stick with one goal, stick with the one Muslim. That's why they said, like, oh, only Allah is, and the Christianity say only Christians are. Why they said that? They said, in case you distract yourself to do anything, distract yourself. If you have some goal and you distract, then it's hard to reach to that goal. So if you believe in one, and then you stick with that path, and you can go up to reach to your goal. This is applied to the spirituality. This is applied to the religion. This is applied to the goals, future for your future life. It's my belief in that. I learn, and this is what I follow. So this is my personal thinking. I'm not talking about any big thing here, but this is what I learned in ashram. Baiji said, like, Neelam, you have to just come to the satsang every Sunday. So you can clean yourself. You can clean your mirror, and then you can see the picture clear, and get ready for the word. Do good things. That's what I learned about. And that's why I started Jivanta to learn more those things, and be together and share the experience. So obviously we learn with each other's experience, and then against technology, education, and somebody's pro in that, it's always help us. So Welcome to Jivanta again. We have Gautam Malhotra today, and he's. I was just laughing in the beginning, and then I said, "Oh, how come whenever you send your detail, and then you didn't mention the Dr. Gautam Malhotra because he's MD, MS, and PhD." And he was laughing. He said, "No, that's not my thing." And I see this is a young generation actually. They are breaking all the barriers, unnecessary barriers, education and all other things. But yeah, whatever you are, you are. You can't deny it. If you are good at something, if you are doing it, and he's very young, and I'm so proud of him to know him. And then he's part of the Divine Art of Yoga family also. So welcome. I want to hear from Gautam, and today's topic is we are talking about the cancer. The this C words is getting really scary now in these days, and I went through actually my personal experience. I my elder brother actually he was passed away. It was so sad because he was perfectly good, living his life fulfilled, and he was happy about it. And one day, like something happened, and they went for tests, and then they find out this something wrong. He was infected with the C word. Like I don't say cancer, I say C word. And then he struggled, he did everything, and then later on he got cured. But after 1 year, like again, he got attacked again with the viruses, and then within a 2 months, means nobody knows like this is happening. So this is what we are talking about. I'm going to share some experience with us, how to screen it actually, and then I don't want to use many words on that one because this is a medical thing. So I'll hand over mic to Gautam. Please go ahead, and then
Okay.
here you are. Here you are. Thank you
Thank
so
you.
much for joining.
Yeah, thank you, Neelam. So let me see if I can share I have some slides I wanted to share.
Can you introduce yourself first, please?
Yeah, 1 second. Let me put
Okay.
my slides. Okay. Sorry, Neelam. I have a new computer that is not allowing me to share. Give me 1 second. Let me get this working.
That's okay. Yeah, we are here. And then again, welcome to Jivanta. And last month we did a Reiki seminar, if you guys remember about it. And we are planning to do the workhouse, the workshop on Reiki. If you are interested in, you can text to us, contact Ashram, or you can contact Jignaben, or you can contact me, because we are planning to do the workshop. And then I want to have people who are interested in, so we can arrange that way. And we are doing in November or December, and Dr. Ajita, she is leading that thing. So please let us know in case you are interested in, so we can enroll you. And it's a life-changing experience, what I heard from Dr. Ajita Patel, because I don't know ABC about these things, but I know the energy. I know whenever you are near some people, you can feel their energy. So yes, I believe in that. So let's learn about that energy more, and please contact us, or you can call or text. Here we go. I think Gautam, he is sharing the slides. Yes, we can see that. Gautam, are you there?
Yeah, can you hear me?
Yes, sir, we can hear you.
Could you hear me before?
No, actually, now I can hear you.
So you didn't hear anything I said?
No, we didn't hear anything. Now I can hear you. Yes.
Can you see my screen?
Yes, I can see screen. Yes, I can see
Okay.
the cursor going on. So all set.
Okay, so thank you, Neelam, for the introduction. So my name is Gotham. I'm blessed and honored to speak with you all today. I've been very fortunate to be part of the Divine Art of Yoga Center for many years, and it's just a wonderful organization that helps give back to the community and all of the constituents. And so I'll tell you a little bit about myself, and then we can talk about the topic today, which is cancer screening. So within medicine, oftentimes people will choose to subspecialize. And so my path has been first general surgery, and then choosing to subspecialize in surgical oncology, which is the surgical treatment for cancer. And so this is a topic that is near and dear to my heart. In my practice, I focus primarily on disease of the liver and pancreas, cancer of the liver, pancreas, and the biliary system. I'm not going to talk about that at all today because there's really no good screening for that. But I will give you kind of a very high level overview of what screening is and examples of successful screening programs. And so also feel free to interrupt in between if you have questions at any point, and then we can have a little discussion at the end.
Yeah,
So,
normally what we do, sorry to interrupt you. Normally what we do, people, they write the notes in the chat, their question, and then we can address them later. So in case I want you to go with the flow, but I have a really one question I want to add it up the front, because I heard about that, like there is yeah, everybody knows it's a different kind of cancer, but I heard like there is for few cancers, there is certain age for screening. So that I was thinking, I said, oh, wow, like if you have to be 25-year-old to do that kind of screening. So yeah, we want to hear more about it. Yes, again.
sure. Yeah, we'll talk about that. There's usually guidelines and age cutoffs for when to start, when to stop screening. We can talk about all of that. And they're specific to each different type of disease. And so first, let me just give you a kind of an overview of why this is important. You know, in the United States, for example, we keep track of many things, including what is the leading causes of mortality in the United States. For example, heart disease has been the #1 cause of mortality for many years. But you can see that #2 is cancer. And in fact, this is from 2019, 2020, the same is true. I just put up 2020 here because it's interesting to see that now we actually have included COVID into as a identified disease. And it's actually #3 for the year of 2020. But what I wanted to draw your attention to was that cancer is the second leading cause of cancer of mortality in the United States, and it's actually projected to overtake heart disease. They had done a study back in 2017 looking at the incidence of heart disease, which is actually declining, and the cancer-related mortality, which is actually climbing. And so it was predicted that cancer would overtake heart disease as the #1 cause of mortality in the United States by 2020. I just showed you the slide previously, which was that has not happened yet, but that trend, this is just an estimate, but that I think is going to be in our near future. If we look at the United States overall, going back to 1999, you can see all these states that are covered in red here. These are areas where heart disease predominates for mortality. And basically the entire United States, heart disease is the #1 cause. But over the years, you can start to see that cancer-related mortality is starting to take over as the predominant factor in some of these states. And over time, these states that have cancer as their leading cause of death is increasing. all the way up until more recently. So now you can see even those states where heart disease still leads um, as the leading cause of death, it's not as dominant as it once was, and many more states are turning blue. And so this is a big issue. So the United States hasn't completely flipped that number one and number two spot, but if we look across the globe, all over the world, um, countries that have high levels of income, many of them have already started to show that cancer-related mortality is overtaking cardiovascular disease. So the low and middle income countries, we don't see this yet. But for the higher income countries, this has already started to happen. And so this makes, cancer prevention by screening and early detection a really important public health issue that needs to be addressed. And so there's a lot of effort that's been put into developing robust screening programs. And so when we talk about prevention, there's different types of prevention. I'm going to talk a little bit about some of these ways, but I'm not going to go into too much detail because it gets very technical. But when we talk about screening the general population, there's three different ways we talk about it. There's primary prevention, secondary prevention, and tertiary prevention. So primary prevention is really intervening before you have the health effects. So for example, trying to stop cancer before it starts, or stop heart disease, or whatever your disease is, you want to stop it before it actually happens. So vaccinations is a good way of looking at that, or, making sure you eat well so you don't become diabetic, or, so that's primary prevention. But when we talk about screening, that's really secondary prevention. So that means that you want to identify the disease at its very, very earliest. So before it has had a chance to get out of control, before even oftentimes the patient is even symptomatic. So you may not even know that you're diabetic, but through a screening program, we can figure that out. You may not know that you have cancer, but if you get a colonoscopy, we can figure that out and then treat you at an earlier stage to have a better outcome. And then there's tertiary prevention. So this is managing a disease that already exists, that exists, and we want to take it from a state where it's out of control and either slow it down or stop the disease progression. So this is kind of the framework within where we think about how to attack disease at a population level. So today we're really going to focus on secondary prevention, which includes screening, and focus specifically on screening for cancer. So, just because we know that there's a lot of different types of cancers out there, well, why don't we just screen everyone for all the different types of cancers? So that's just not feasible. There's a lot of component that go into creating and developing an effective screening program, and not every disease is amenable to having a good screening program. So you need to have a few things in place for that to be effective and useful for the population. So things, if you break it down, if you think about the disease has to have certain characteristics. So it has to be an important health problem that really affects the population. So with a high prevalence. So what that means is that it has to be prevalent enough within the population that there's enough people that this disease affects to make it worthwhile to screen. So if you have, for example, I mentioned I work on pancreatic cancer, and that's a very rare disease. So it doesn't really make sense to screen the entire population, everyone, for pancreatic cancer. But things like breast cancer, which is much more common, much more prevalent, it's much more useful to screen the entire population. So we also need to know enough about the natural history and the condition to allow for early detection. And then the screening test has to have certain characteristics. It has to be there. First of all, there needs to be a good screening test available. So again, for pancreatic cancer, it just doesn't exist. We don't have a good screening test. Number two, even if you do have a good screening test, it has to have certain characteristics, such as high sensitivity. So what that means is a good screening test should be able to look at a population of people and choose out the patients or the population that it thinks is has a potential for having that disease. So we call that high sensitivity. So it's okay for a screening test to have potentially false positives, because the job of the screening test is to take anyone. So basically what you want for a screening test is that if it says that you don't have the disease, then you can feel very confident that you don't have that disease. And then the people that screen positive go on to have a confirmatory test that is highly specific. The healthcare system has to have certain characteristics. You need to have effective treatments for that disease, because if you screen the population, you find the patients who have this disease, if you can't treat it, there's no benefit. And that treatment should ideally be more effective if initiated earlier. Otherwise, there's no benefit to finding and screening that population. So let's just say, we find certain disease earlier in its course, but if we had found it 1 year or 2 years later, it wouldn't make a difference. So there's no benefit, if there's no difference in the outcome. And then there has to be appropriate follow-up and confirmatory testing. So this is what I was talking about. The screening test should be highly sensitive, and then the confirmatory test is highly specific. So the ideal screening test should be cheap, sensitive, meaning that it will have a very low false negative rate. It should, ideally be specific, but that's less important. It should be accessible to the whole public. It should be safe and acceptable. So then, taking all of this into account, which diseases what types of cancer should we screen for? Because I mentioned we can't feasibly screen all the different types of cancer. It would be cost prohibitive. So
yeah, you mentioned that about the breast cancer, like they always send every year that go for that, and I really tell everybody like it's a good idea to go there, because sometimes like I even like in the past years, like sometimes I skip it. I said no, I don't want to go there. It's no necessary, but I think it's a good idea after
yes,
listening about that. Yes,
definitely, 100%. We'll talk a little bit more about breast cancer screening, because that's a very important health topic. Okay, so what I was saying is, well, what should we screen for? So here's a list of cancers, the top 10 for males and females. And like I said, we can't screen for everything. So what should we screen for? Well, also the other thing to take into consideration is how severe is that disease, because not everything that is very common results in cancer-related death. So for example, if we look at certain things like pancreas cancer, which is very low on this list, that is actually a really highly lethal disease. It's the fourth leading cause of cancer-related death, even though it's one of the least common cancers. Likewise, we have things like melanoma, which is a very common disease, but that doesn't cause much mortality. And so we have to find a balance between all of these. But one of the characteristics I mentioned that you need to have for a good screening program is a high prevalence. That means it has to affect a large number of the population. So if we look at the leading causes, or the most common, at least the most common types of cancers, for males it's prostate, for females it's breast. And then after that, the second most common is lung cancer. And then following that is colon and rectal cancer. So these are good types of cancers to screen for. And then I'll talk about each one of these. And in addition, I'll talk about melanoma at the very end if we have time. So this is what I'll talk about: breast cancer, cervical cancer, lung cancer, colon and rectal cancer, and then melanoma. So we'll start with breast cancer. So to your point, this is a very important health issue, because we have almost 300,000 new cases every year, and unfortunately 40,000 mortalities every year. So it's one of the most common types of cancer in the world, the most common in the United States, and it's the second leading cause of cancer-related mortality for women in the US. Now, the majority of these breast cancers in the US are actually diagnosed as a result of an abnormal screening study. And so I'm sure everyone's familiar. Mammograms are the screening modality most commonly used for breast cancer. And so it's been a very effective tool. But I should point out that even though the majority of these breast cancers are identified and diagnosed as the result of a screening study, the majority of those are actually brought to the attention of the physician by the patient. So it's really important to know your body. And if you feel like there are any concerns, bring that to the attention of your physician. And like I said, this has been a really successful screening program because it fits all the characteristics that we have. It's a very common disease. We have very effective, cheap, easily available screening, which is mammography, which is basically just an X-ray of the breast tissue. And so that can be done very effectively all across the United States. You don't have to be a very specialized center. And so it's accessible, it's cheap, it's easy and acceptable. And so you can see that the mortality for breast cancer going back to the 1970s was very high. And it's really started to come down quite significantly. And this is a combination of factors that have allowed this to happen, including starting the screening program. So the American Cancer Society in 1976 implemented the first recommendations for screening mammography. And you can see within 10 years, the incidence of, the mortality from breast cancer started to decline significantly. So clearly screening has worked for this disease type, but what does that really mean? What does that look like? So in the beginning, it was a very crude and rudimentary, as is true for anything in medicine or across, the world. If you're trying something for the first time, it takes a little bit of time before you become very good at it. But for breast cancer, now we have a much better understanding of not just, how to screen for it, but the disease process itself. And we can be very much more granular in our approach. So essentially, we base our screening for breast cancer. The protocol is very individualized to the patient and specifically their lifetime risk for breast cancer. And so how do we know what is your risk of breast cancer? Well, I mean, as a general population, we can say, yes, about 12.5% of women, unfortunately, over the course of their lifetime will develop breast cancer. So that is 1 in 8. So 1 out of every 8 women will develop breast cancer in their lifetime. And 95% of the population falls into this average risk category. Like I mentioned, we know a lot more about breast cancer. We know a lot more about genetic mutations that put you at higher risk for breast cancer, syndromes that are associated with breast cancer. And so not everybody is in this average risk population. There's also a high risk population. And these are people that have varying levels of risk for developing breast cancer. And this is based on a constellation of factors. I'll talk to you about the risk factors for this on the next slide, but we have risk prediction models that we can use for the average person to assess their own personal risk. So there's a lot out there. If you Google this topic, I think you'll be overwhelmed. I put a few of probably the best quality risk predictors here. So the NCI, the National Cancer Institute, has their own breast cancer risk assessment tool. This is, many years ago, you may have heard of something called the Gale model. This is a modification of the Gale model. It's one of the better tools. The Breast Cancer Surveillance Consortium has their own risk calculator, and the Tyrer-Cuzick model has been around for a long time and is still very well respected. Then obviously there's patients who have underlying genetic mutations. I'm not going to go into details of these. We can talk about it at the end if people have specific questions, but I'm sure you've heard of BRCA1, BRCA2 mutations. This puts you at higher risks of not only just breast cancer, but other cancers as well. And then a few other gene mutations that are not as well publicized in the media are things like P10, P53, CDH1. So what I'm going to focus on really is the average risk population, because remember, 95% of the people fall into this category. Even within this category of average risk, there's a lot of different things that happen over your lifetime that will determine your risk of breast cancer. Some of these things that we can control, and there's some things that we can't control. So, for example, genetic mutations, you can't control that. If you have a germline mutation in BRCA1, BRCA2, or some of those other genes I mentioned, then you're just inherently, unfortunately, at a higher risk of developing breast cancer. Family history of cancer, just in general, puts you at a higher risk of breast cancer. If you've had previous chest wall radiation, specifically before the age of 30, that puts you at a higher risk of breast cancer. This, unfortunately, was commonly used for Hodgkin's lymphoma, much less so today, but unfortunately, those patients are at a higher risk of developing breast cancer, as well as other soft tissue cancers in the area of the radiation. Your menstrual history plays into this as well. Having early menarche, starting your menstrual period before the age of 12, or having menopause after the age of 55 puts you a little bit higher risk of breast cancer, because essentially you have unopposed estrogen over a longer period of time. Conversely, if you have children at a younger age, that is protective for breast cancer, because it induces differentiation of the breast tissue and decreases your risks of breast cancer. Dense breast tissues, unfortunately, this is again outside of the control of anyone. That makes it more difficult for the mammograms to identify small, subtle lesions. And so this puts you at a higher risk of developing breast cancer. That's undetected, I should say. But then there's a whole list of factors that are within your control. And so those are things that are good to be aware of, because these are what we would call modifiable risk factors. These are things that are within your control. So exercise, everyone has always said that exercise is good for you, and the same is true in the world of cancer. Even as little as 30 minutes of exercise a day can decrease your risk of breast cancer. Not being overweight will decrease your risk of breast cancer, because when you're overweight, the excess adipose tissue, the fat, we have enzymes that convert fat into estrogen, and that puts you at increased risk of breast cancer. Alcohol, similarly, will increase your risk of breast cancer, as well as a whole list of other cancers. Hormone replacement therapy, that includes estrogen, progesterone during menopause, will actually, unfortunately, increase your risk of breast cancer as well. And then reproductive history. If you're not breastfeeding, or if you have children after the age of 30, unfortunately, that also puts you at a higher risk. But conversely, if you do breastfeed, or you have children at an earlier age, like I mentioned, that is protected. So outside of these modifiable risk factors, you can use one of the models to determine your risk. But then what do we actually recommend for the average risk person? So there's a lot of different, I will tell you, societies, foundations, organizations that will put forth recommendations on cancer screening. So you can see here, for example, the American College of Obstetricians and Gynecologists, the American College of Physicians, American Cancer Society. These are all great organizations. I think the two that I will highly recommend would be the U.S. Preventive Task Force Service, the USPSTF. This is the government's kind of organizing body that will take a look at all of the existing literature, research, clinical trials, and consolidate all of that information to put forth recommendations. And so this is a organization that I will look for. And then the other one is the National Comprehensive Cancer Center Network. So the NCCN, you may have heard of, they put forth guidelines and recommendations for treatment of almost all of the cancers that we treat. And it's very, very comprehensive. It will talk about screening, workup, treatment, surgery, chemotherapy, everything. So what is the actual recommendation? So for women,
can I ask you quick something right here? Because
yes.
So why this the years mentioned about like 2016, 2017? What is the meaning of that?
That's when these guidelines were published.
Published,
So,
okay.
so yeah, some of them are a little bit older, some of them are newer. The NCCN, this one, will publish new guidelines every year, and honestly, it will continually revise their guidelines. And so this one is maybe one of the best, most comprehensive guidelines to look at.
Yeah, that's you answer my question, like who is the one who is updated one? They are doing it, but you prefer that NCS. Okay.
Yeah. And then so the this one, the USPSTF, they don't update very often. The NCCN will update all the time, every year. Every year there will be a new guideline. And so, I mean, there hasn't been any changes in their recommendations. So, I mean, the last time there was a meaningful update was 2018.
Okay, thank you.
So, so again, just to remind everyone, this is for the average risk. That's what we're going to focus on, because for all of these different types of cancer, that's where most of the population will fall into. So when should we, so we know the screening is mammography. When do we start? This is one of your questions as well. So age 40 to 50, 40 to 49, they say that, and the other thing to keep in mind is that you can see here, there is no one consensus, right? So all of these different, these are all very competent, organizations. They have differing, recommendations. So age 40 to 49, the U.S. Preventive Services Task Force says it's kind of an individualized decision between you, the patient, and the physician. But the NCCN says, yes, you should have it done. So typically my recommendation is at age 40, moving forward, you should have breast cancer screening in the form of mammography. How often do you want to do it? The NCCN says every year, USPSTF says every 2 years. So between 1 to 2 years, I think is fine. So this should continue, from age 40 to age 70. And then after the age 70, many organizations will say yes to a certain point. Age 75 is generally considered a cutoff where at that point, you may not need to continue to do some screening. Sorry, Neelam, did you have a question? You're muted, sorry.
Oh, sorry. Yes. Yeah, a few questions, like, because whenever you're showing the slides, so I want to put those questions in. I know we can go at the back, but those are the different questions. I have a question right here. So you said 40 to 49 age, that's a good age, like you can scan it.
Mm-hmm.
So is it like a very costly, means anybody can go and ask them to do it, or you have to have certain condition to do that?
No. So when we talk about screening, it'll change a little bit later. So there's some screening which is for the general population, which means everyone, no matter what, should have the screening done, right? When we talk about colon cancer, we'll talk about that, here in a little bit. It doesn't matter who you are, you should have it done at a certain age. We'll tell you that age. Same with breast cancer. But there's different other types of cancers, for example, lung cancer. Not every single person in this country needs to have screening for lung cancer. If you never smoked in your whole life, you don't need screening. But if you were a former smoker and you're at a certain age, then yes, you fall into that category. So for breast cancer, to answer your question, this is for everyone. You don't have to have any symptoms. You don't have to have any disease. You just have to be a female, age 40 or greater. You just go to your doctor and you say, hey, I'm interested in breast cancer screening. Can we set up a mammography? The cost, I'm not sure. It's going to be, variable, but insurance will usually cover this, because the thing is they have insurance based their coverage on published, a lot of it, not everything, but a lot of their coverage is based on published guidelines and whatever Medicare will reimburse. And so usually for screening, they will cover that.
Okay, thank you.
Yeah. Okay, good. So then there's also an age where we discontinue surveillance, because after a certain point, where the thought is, look, the benefits may not apply to you anymore. It's because after a certain age, it is less likely that you will ever, you know, die from the actual cancer. Something else might affect you first. And so it's not necessary or beneficial even to continue screening at a certain age. And I can tell you from experience, many patients get tired and they're very happy to discontinue their surveillance at a certain age. So people, if you want to see this in a different graphical format, you can see here that in the beginning, age 40 to 50, a lot of this is shared decision-making between the physician and the patient. If you're anxious or if you have concerns, then yes, go ahead and there is data to support screening. After that, you should have regular screening up to an age of around 75. So far I've talked only about mammography, which is the mammograms, the X-rays, because that is the best screening modality we have. In a lot of patients may ask about MRIs because we do use MRIs for breast cancer workup, but it's not recommended for screening for the general public because it is very sensitive. It has a lot of false positives, and it will lead to unnecessary workup and sometimes even biopsies and invasive procedures. So MRI is really only used in special circumstances. If you have a BRCA gene mutation, if you have a first-degree relative who has a BRCA carrier and you haven't been tested yet, or if based on one of the prediction models, you have a lifetime risk of greater than 20% of having breast cancer. If you've had previous chest wall radiation or other genetic mutations, then MRI is used. The other thing I'll talk about is, you may have heard in the past, is about clinical breast exams or breast self-examinations. So in the past, a lot of people and societies would recommend having an annual clinical breast exam or doing your own self-breast exam at home. And there's certainly no harm in doing that, but more recent studies have suggested that there really is no benefit, that our screening is so good that we will be able to identify, detect, and treat the breast cancer as long as you're keeping up with your normal screening. Okay, so I know breast cancer especially is going to be a very hot topic, but I wanted to focus on screening, cancer screening in general. And so there's a lot of, the topic of breast cancer, any one of these topics could be a whole day worth of discussion. So I'm not going to touch upon these. We can talk about it at the end if we have time. The breast cancer diagnosis and workup, how do you actually work that up? Different types of imaging. We talked about, mammograms. We talked a little bit about MRIs, ultrasounds, biopsies. We can talk about that later. Genetics, BRCA, and the others. We can talk about that later or at a different time. Subtypes, I'm sure many of you are familiar or have family members because it's so common. 1 in 8 women will be afflicted with this. ER status, PR status, HER2, triple negative, basal, luminal. We can talk about that later. And then treatment. I will say that of all of the cancers known to humans, breast cancer is probably the most well-studied and characterized cancer. And this is likely due to how well funded and how prevalent the disease is. And so because of that, we know quite a bit about this disease. The research and the treatment for breast cancer is much more advanced and better understood than any other type of cancer we have. And so good, in fact, that we have targeted treatment that can actually, I usually never use the word cure, but can remove or cure your cancer with rates as high as 50%. Okay, so the other common cancer that we should talk about briefly is cervical cancer. So this is a very common type of cancer among women worldwide. Its prevalence is decreasing a little bit in the United States, and a lot of that is due to primary prevention. I'll talk about in a little bit. Oh, here it is, yeah. So it's less common in developing countries, and a lot of this is due to vaccination and screening. And so, unfortunately, if we look at the worldwide population, 85%, which is the vast majority of cervical cancer, is originating and is from regions that are resource limited. We also have a good understanding of this disease process because we know that it is very significantly impacted by this human papillomavirus, which is actually a virus that can be passed on and spread. And this is the actual cause for about 99% of cervical cancer. So there are over 40 different types of subvariants of the HPV virus. Only a subset of those are high risk for causing cancer. The two most common ones are HPV 16 and 18. And so these two subtypes alone are responsible for about 70% of the cervical cancers. This is also the same HPV that is responsible for anal cancer. And so it's a well studied pathogenesis. So why is the incidence decreasing? Well, as I mentioned, this is largely due to screening, but also vaccination. So if you go back to the earlier part of the talk, remember when I talked about primary prevention. So primary prevention is stopping it before it ever has the chance to start. And so vaccines are a way to do that. And so we actually have 3 different types of vaccines. Many people are probably aware of the Gardasil. The Cervarix is another bivalent vaccine. This only targets HPV 16 and 18. But the one that is available here in the United States is Gardasil 9. It's one of the more comprehensive vaccines, and it targets 9 different subtypes. It includes 16 and 18 here, which are the most important, but then also several others, which are lower risk HPV variants. And so vaccination is recommended for all, not just females, but all females and males from age 11 to 26. And so again, you just walk into your doctor's office. In fact, they should be telling you, but if they haven't, you just walk in and say, hey, I need vaccination for HPV. So, then the question is let's say you have this vaccine, do you have to still undergo screening? Yes, you do. But let's say you don't have this vaccine, then of course you still need to go on to surveillance. So what are the screening recommendations? How do we do it? So similar to breast cancer, it's actually related to your risk. So we have the average risk population. This is again what we're going to focus on. These are asymptomatic patients, immunocompetent, no previous abnormalities on their cervical pap smears, no high-risk behavior. The high-risk population falls into a different category. These are people, unfortunately, who have potentially immunocompromised from either transplantation, HIV, prior exposure to DES is a synthetic estrogen that was used many years ago. And if you were pregnant at that time and were exposed to DES, then you have a higher risk. So what do we do for cervical cancer screening? So again, this is the USPSTF. This is the United States Preventive Services Task Force. And so they have put forth their recommendations that starting at age 21, you should undergo a cervical cancer screening, even if you have already had a vaccine. And so what do you do? So ages 21 to 29 is just a pap smear or a Papa Nicolau stain every 3 years. After age 30, then you choose one of these methods. You can continue to do your pap test every 3 years, or we have HPV testing. This is serum testing. You can do that every 5 years, or you can do combination testing. So early cervical cancer is frequently asymptomatic, and so that makes this screening very useful. Even symptoms when they do present are very vague, and so that makes the screening more important and effective. The next topic we can talk about is lung cancer, because again, this is the second most common cancer that affects the U.S. population. Sorry, did you have a question? No, okay. So unfortunately, lung cancer is very common. We have in the United States, I think it's about 120,000 mortalities of lung cancer every year. But that is minuscule compared to if you look at the globe. In the world, it's about 1.6 million people who die from lung cancer every year. And so it's a very serious problem. And it's really sad because this is almost universally believed to be related to smoking. So similar to cervical cancer, primary prevention rather than screening is the best strategy for reducing this burden. As I mentioned, most of lung cancer is attributed to smoking. Even those patients who've never smoked in their life, we believe that if they develop lung cancer, it's likely due to environmental smoke exposure, either from their environment or secondhand smoke. And so in this case, primary prevention, which is essentially smoking cessation, is the most important thing you can do. So, for a long time, we didn't have a lung cancer screening program because it was not an easy thing to do. The chest x-rays are not good enough to identify early stage lung cancer. You can see it on a chest x-ray, but usually at that point, it's rather advanced. And that goes against, our goal. Our goal with screening is to identify the disease in its early stages, so that way you can treat it and have better outcomes. And so x-rays were no good. CTs are really the best, but, CTs were very expensive, initially. That cost has come down quite significantly, but also CTs expose you to quite a bit of radiation. It's not a trivial amount, especially if you're going to need to get a CT scan every year. And so for those reasons, for a long time, we didn't have a good screening program for lung cancer. And also, we need to identify a subpopulation. We don't want to screen everyone in the United States, but maybe only those patients who have smoked. So we have to identify a subpopulation that's high risk, and then identify a cost-effective, accessible screening tool. And so that we finally do have with the development of these low-dose CTs. They provide a very limited CT of the chest, which is good enough for identifying lung cancer, but with only a fraction of the radiation exposure. And so these low-dose CTs will give you about 15% of the radiation that you would normally get from a full high-quality CT scan. So this, coupled with that targeted population, makes screening program possible. And so what is the benefit? Well, there's the improvement in morbidity and mortality. The disease has a long preclinical phase, so that means screening will be useful. And the treatment is definitely more effective in its earlier stages. And so we talked a little bit about radiation exposure and how we came around that. And so what is the actual recommendations for lung cancer? So again, there's many different organizations. All of these are very good organizations. You can see here on the right when they publish their guidelines. But the recommendations from the USPSTF are actually relatively new, just from last year. And because these low-dose CT scans are still evolving. And so now we have the NCC and the National Comprehensive Cancer Network and the USPSTF both recommending low-dose CT scans for high-risk individuals. So who are high-risk individuals? You can see there's a little bit of variation in their individual definitions. But I'll show you on the next slide. The NCCN, as I said, they change their recommendations every year. So essentially it's for patients who are age 50 and greater with a 20-pack-year smoking history. So this is the latest, I would say, like the final word on lung cancer. So high-risk individuals, these are age 50 and greater, 20-pack-year smoking history. And so these patients should go on to have a low-dose CT scan for screening. So very, very straightforward, but a very effective option. I want to leave some time for discussion at the end, so I'll talk quickly about the last two topics, colon and rectal cancer screening. This is another thing that's probably very well known to the audience, either from personal experience or family and friends. But before, everyone I think is a little bit more familiar with some of the other lung cancer, colon cancer. I just want to kind of orient everyone because maybe there's a little confusion on what exactly is the colon. So usually when you eat food, it comes down your food pipe, the esophagus goes into your stomach. After your stomach, the food goes through this small tube here. This is the start of the small intestine. So the small intestine is all of this right here, all of this in the middle. And that small intestine goes all the way, loops around, lots and lots of small intestine until it plugs into this large intestine. The large intestine is its colon. So the colon and the large intestine are synonymous. They're the same thing. And so the large intestine is broken up into different parts. There's the right side. This is the patient's right side here. That's the ascending colon. Then there's this part that goes across the top. This is the transverse colon. And this part that goes down. This is the left side, the descending colon. And then you may hear people talk about this part right here from here to here. This little loopy part is called the sigmoid colon. And then after that, the colon turns into the rectum. That's a different organ, essentially. And so there's a difference between colon cancer and rectal cancer, even though, they're in continuity and they're treated very differently as well. And then the stool comes out of your bottom. So that's just the anatomy of the GI tract. Colon cancer is very common. You saw that it's the third most common cancer. And actually, I believe it's the third leading cause of cancer-related mortality as well. But it takes a long time to progress. And we actually have a pretty good understanding of how colon cancer progresses. It's estimated that it takes maybe 10 to 20 years for colon cancer to develop and turn into a truly invasive malignant process. Many people have probably heard about colonoscopy, polyps seen on colonoscopy, removing those polyps, and I'll explain to you why. Essentially, what happens is the colon is like a tube, a hollow tube, and your food and your stool is passing through the colon. Sometimes you can have gene mutations that happen just randomly, just sporadically, and that can cause a little polyp to form. So one of the common genes is this APC gene, and then maybe you get a little polyp, a little overgrowth. But that's no problem. That's just we call a benign polyp, and it's just growing and protruding into this hollow tube. But if you get additional mutations, and this is just left in there without anything being done, then eventually it can turn into an actual cancer that can invade and spread to the most common places are places like the liver and the lungs. And then that's what we call, metastatic disease. But this whole process takes a long time. And we understand that process relatively well. We know that if you have a polyp, sometimes it starts off as, maybe a hyperplastic polyp or a little bit faster growth or hyperproliferation, and it turns into these things we call adenomatous polyps. They can be small, they can be large. And then these are just normal, colon cells, but sometimes they can become a little abnormal. If they become abnormal or have atypical cells, sometimes the pathologist will call that dysplasia. There's different levels of dysplasia. This is not cancer. Even though there's atypical cells, this is not cancer. It's only cancer when it invades this underlying layer. So you see here, there's all these atypical cells, but they're just staying here within this polyp. Only when they break through this barrier, then we call it cancer. So we know this process very well. And so a long time ago, we started implementing a screening program where you could go in with a camera and look to find these polyps and remove them. So again, I'm going to talk really about the average risk population. There are some high-risk population that need specialized screening. These are patients that have history of multiple polyps or a family history of colon cancer, or there's a lot of genetic syndromes that can put you at a very high risk of colon cancer, like familial adenomatous polyposis, Lynch syndrome. You may have heard of some of these. Some of these, essentially, colon cancer is guaranteed. And so for those patients, they start screening much earlier and will actually have their colon, the entire colon removed prophylactically before cancer develops. But for the average risk population, these are patients who don't have any history of polyps, don't have a family history, really no genetic syndromes, no inflammatory bowel disease, no immunosuppression. What do we do for them? Well, we need to start to screen them and look for these polyps before they become a problem. And so when should we start doing that? Well, if you look at the incidence of colon cancer, I mean, you can see here in the young population, really, there is very, very low risk of developing colon cancer. That risk actually starts to go up significantly somewhere around here, right? So age 50 has historically been the cutoff. If we look at the data, 90% of colon cancer occurs in patients that are age 50 or greater. And so historically, this has been the cutoff for screening for a long time. However, in the last few years, unfortunately, we've started to see an increase in the incidence of colon cancer in the young adults, so age 40 to 50. And that's the incidence of colon cancer in that population, 40 to 50, has increased by almost 15%. If we look back at 2000 to 2002, up till 2015, that population of age 40 to 50, the incidence of cancer has increased by 15%. So the American College of Gastroenterologists had put forth recommendations, to change that age when we start colon cancer screening from 50 to 45 several years ago. But the U.S., remember, this is the same organization, the USPSTF, they had not really updated their recommendations until last year. So in 2021, they updated their recommendations and they started recommending screening at age 45. So that's relatively new. And so this is a grade B recommendation, but they emphatically want to make sure that no matter what, you start screening at age 50. But honestly, recommendations that we put forth to patients is that at age 45, they should start colon cancer screening. So how do you screen for colon cancer? There's a lot of different options. I'm sure many of you may have heard of some of these. There is the good old trusty colonoscopy. That's once in every 10 years. There's this FIT. This is the fecal immunochemical test. This is essentially looking for blood, like microscopic blood in the colon. It's the same as this, or very similar to this, not the same. This is fecal occult blood test. And so this is looking for blood in your stool that you can't see. And so these are two options as well. We have this CT colonography, which is essentially like a CT scan with a special preparation. So that way it can look at your colon. And then there's this FIT DNA. This is like Cologuard. It's looking at multi-targeted stool DNA test. So what's the best? Well, to be honest, what I would say is clearly colonoscopy has the highest sensitivity of identifying polyps, right? Polyps are those precancerous lesions. If you look here at these small polyps, these are less than half a centimeter. These other tests really can't see these small polyps very well. These larger polyps, the colonoscopy sees well. Some of these other methods, like the CT colonography, are also decent. This FIT Cologuard is relatively good at identifying actual cancer, but not so great at polyps. So personally, I think colonoscopy is the best. You get direct visualization of the colon. You can actually intervene. You can biopsy. You can tattoo. You can actually get tissue samples. Oftentimes, even if there's a small cancer within a polyp, if you remove that polyp completely, you're done. You don't need to have anything more. So I think this is many people's preference for colon cancer screening, but the truth is, in reality, the best screening test is the one that the patient is going to actually complete. So if you say, hey, get a colonoscopy, and the patient says, no, I'm afraid of the prep, I don't want to do it, and they don't do it, for that patient, one of these other things is better, because it's better to have something than to be scared of a colonoscopy and never get it done. And also keep in mind that if, let's say, your FIT test or your Cologuard has some abnormality that it shows on its report, you then have to proceed to a colonoscopy anyways, regardless. And so I think for many people, colonoscopy is the gold standard. So then what do you do after you get a colonoscopy? Well, if you have all clear, you're good to go for another 10 years. And that's great. Most people will fall into that category. A lot of people, will find, some small polyps, and that's not uncommon at all. And so based on the number and the size of the polyps, you may get a range from your gastroenterologist or your colorectal surgeon to say, hey, come back and see us in 3 years, 5 years, 7 years. So if you do get that, don't be alarmed. This is just part of the screening. And so then you just continue to follow up, and God willing, that's where it ends. So the last thing, we're running out of time. The last thing I want to talk about is melanoma. So do we screen for melanoma? Because you might be thinking to yourself, oh, I've heard of lung cancer and colon cancer and breast cancer. I've never really heard of, melanoma screening. Well, the truth is, no, we don't screen for melanoma. The USPSTF, has put out their recommendations, and there's insufficient evidence to say that there's any benefit for screening for melanoma. So the only reason I'm talking about this is because we live in California. We have, almost 300 sunny days a year, and we know that sun exposure and UV rays are one of the main risk factors for developing melanoma. So I just wanted to put this out there on your radar, so you're aware of it, so you know what to look for. Essentially, the UV rays from the sunlight and other sources like tanning beds, which are horrible, and I wouldn't recommend anyone do, tanning beds. They cause DNA damage, and that causes mutations and abnormal growth that can lead to cancer. One thing I want to mention is that this is there's a huge difference in the risk for developing melanoma depending on your ethnicity. The Caucasian population is at a much, much higher risk of developing melanoma than even Hispanics, Native Americans, Asians, and African Americans. And part of the reason for this is because all of these subgroups have some pigmentation in your skin, as we do. And pigment in your skin is essentially, it's melanin, and it comes from these melanocytes, and that gives you some protection against the harmful UV rays. And so that's why we have a little bit lower incidence. But I still think it's very important, even for us, for everyone, if you're out in the sun, you should use sun protection, and that can be various forms, either long sleeve clothing, hats, or sunscreen. So who's at risk? I mentioned these are usually more white adults, age 50 and over. If they have multiple little nevus, these are freckles. If they have large atypical nevi, if you have a personal history of previous cancer, immunosuppression for any reason, HIV or transplantation, and then this is what many people talk about, and it's important. Light skin, red, blonde hair, people who sunburn easily, people with light colored eyes, if they have a family history of melanoma, these are patients who should be more vigilant. So the last thing I want to do is just show you what to look for, because again, nobody's going to know your body as well as you. So if you see something new, something concerning, bring it to the attention of your physician, your primary care doctor, who can look at it and then refer you on to a specialist if needed. So these are the ABCs of melanoma. It's easy to remember. So just think A, B, C, D, E. What you want to look for is any type of asymmetry. So this is normal. This is abnormal. You see this is not symmetric. There's a raised lesion here and then this asymmetric border. The other thing you want to look at is border. B is for border. This is nice and smooth and well circumscribed. This is irregular, large, spreading, and not necessarily as smooth. Color, this is a normal, melanin type color with pigmentation. This is looking very dark, hyperpigmented. That's abnormal. Size, diameter. So ABCD is for diameter. So if you have a small lesion, less concerning. If it's a large lesion, greater than 1/4 of an inch or 6 millimeters, then that's more concerning. And then E is for evolution. If you see this lesion, it looks the same, 6 months from now, a year from now, even if it was looking a little concerning, then that's less worrisome. If you have a lesion and in 1, 2, 6 months, it turns into something else, that's more concerning. And so those are things to look for on yourself. I think I will end here. We have some time for questions and discussion.
Yeah, thank you so much for that information. One side is kind of scary. The other side is like, oh, there are solutions also because we have to face it, whatever the reality is. So I'm going to take some questions right there. I think I see some people post that questions. How do you find your genetic predisposition?
I'm sorry?
Predisposition. If you can see the question.
It was genetic predisposition for the breast cancer. Is it a blood test or?
Oh, yeah. So, so there's two things for breast cancer. If you want to determine your risk for breast cancer, you can go to any one of those 3 models that I described. If you want to know about your genetic predisposition, usually you need to have a family history that would raise suspicion for any type of genetic predisposition. If you do have that, then we send you to a genetic counselor and they can do testing. Usually it's even a cheek swab is enough to get you germline mutation analysis.
Okay, thanks. I was just curious. Thank you.
Yeah, and then there is one more question. Gautam, can you read out?
Let me see if I can find.
Yes, in the
Here,
chat box.
Let me stop sharing for 1 second.
Oh yeah, you can do that.
Chat. There we go. I have a question for you.
If you want, you can turn on your camera or audio.
Can you hear me?
Yes, we can hear you. Yes.
So this is a question about the growing trend in cancer-related morbidity. Do physicians feel this increases because more people are being screened, so it's being reported more? Or is it because environmental factors causing more cancer? Why is cancer so rapidly becoming the high? Oh, that's a good question. So I think the question they're asking is, so I'll just say morbidity and mortality are often used hand in hand. But I think what they're asking about is why are we seeing a growing number and an increase in cancer? Is it because we're looking for it more? Is it because there's toxins in our environment? And so that's a good question. I think it's a combination of all of the above. I can talk about why cancer is eclipsing cardiovascular disease as the #1 leading cause of mortality in the United States. That I think is going to be a combination of decrease, or we're doing better at decreasing the mortality associated with cardiovascular disease. And so as that curve comes down, cancer is going to overtake it. At the same time, I don't want to leave you with the impression that all cancers are increasing in incidence. That's not true. In fact, most cancers and cancer-related mortality is declining over years. There are a few where it's increasing, but that's rare. But because we're getting better at treating other diseases, and we're also getting better at detecting and identifying cancer with our screening, then naturally we're going to have an increase in incidence of cancer and a decrease in in the other diseases.
I want to add one more thing in that, like you mentioned, it's the high income countries. Why is that?
I think that's back to the same issue, because in these countries with high amount of resources, there's a better ability to treat preventable or prevent death from preventable causes. So if you have cardiovascular disease, if you have a resource-rich country, you can treat that with, medications, with surgery, with bypass. If you don't have those resources, then unfortunately you'll succumb to that disease. So as we get better and at treating these other diseases, cancer for which there is in some cases not a very good treatment, will overtake that.
I have another follow-up question to the question about is cancer becoming more prevalent? You said something about colon cancer and about how there's been a pretty large percentage increase in younger people getting colon cancer. Why do they think that is?
We don't have a good understanding of why that's happening. Almost certainly there's going to be a environmental lifestyle component to that.
Mm-hmm.
But we don't have a clear understanding of why that's happening.
Thanks.
And one time you mentioned about like for lung cancer, it's like smoking, definitely it's a bad habit, and then alcohol also, because in this present future or in present, like what even women start drinking, and they were talking about like, oh, wine is good for health, because I grew up not drinking anything, but I saw my father was drinking, and he used to take like one because he's an ex-military man, so he used to take one shot like or one peg every day or two pegs. So, but now I see like even in India, even here also, like even women are talking about like, okay, wine is good for your heart, good for your health. So you mentioned about alcohol. Do you can you mention like what kind of alcohol you're talking about?
That's a good question. So anything, this is kind of broadly applicable. Anything in excess is going to be bad for you. Anything, even, oxygen, water in excess will be harmful to you. And so the same is true for alcohol. If you have one glass of red wine, even every day, that there are studies, people that are talking about, there was a study published in a prominent journal, which said 1 glass of red wine for women, 2 glasses for men a day, coupled with regular exercise, is beneficial for your heart. Okay. So, I mean, I believe that's believable. But if you're just sitting there having 1 bottle of red wine every day, you're not exercising, you're overweight, that's not going to be good for you. If you're having excess of anything, that will be harmful. And so I don't think it necessarily means that it's any specific type of alcohol, beer, wine, liquor, but excess of anything will be harmful.
Very smart answer. I was thinking, mention, no, you can drink beer, or no, I'm just kidding.
No, I mean,
I know it's a serious
but
matter.
in moderation.
Mm-hmm. This is a serious matter we are discussing, but yeah, we have to take it a little bit lighter also. So that's why I put some things in there. I have another question on this one. You said you saw like the COVID is going on and we faced like almost 3 years. So that affects our immunity. Everybody talk about like, how about, is it like open to having cancer because our the immunity is less, or what do you think?
No.
What is the medically they are talking about?
So I don't think COVID infection will cause enough of immunosuppression to put you at risk for cancer. So when I say immunosuppression, I'm talking about long-term immunosuppression. Those are patients with, for example, HIV, because HIV attacks your immune system. It makes you vulnerable to different types of infections, or patients who have had, some sort of solid organ transplant. So if you have, liver transplant, kidney transplant, you're taking an organ from some other person, putting it in this third person, and your body obviously knows that that's not my own tissue, and so it wants to fight that organ. So we have to suppress the immune system so that way it doesn't destroy that new organ. And so those patients, their immune system is suppressed by us, by the medication we give them, and then they're at risk for developing infections, inflammation, and we know that inflammation and chronic infections and chronic inflammation puts you at risk for cancer. And honestly, even though it may not be studied for every different type of cancer, I guarantee you, if we had enough resources, we would find a link between, chronic inflammation and almost every type of cancer.
Okay, yeah, no, you're answering all the questions actually. And then in one area, you talking about the colon cancer, and then you show a picture. If the line goes a little bit up, if the infection is up, it's not, it doesn't mean it's cancer, but if whenever it go lower, hitting that line, then it is a cancer, right?
Yeah.
So is there any symptoms, because it's a colon cancer? Because you, even doctors, like whenever you go for any medical test, they said your urine, your stool, and they test it. So is there any way like we can pay attention whenever we go to clean ourselves in the morning, to pay attention like, oh, what is happening? I'm not trying to scare anybody or not myself, but a little bit paying attention. I think this is, it says it's our body, and then we have to just pay more attention what is happening, and then you can handle things. So any suggestion medically, like, oh, paying attention to whenever you poop, and then to make sure like, okay, if it is like in a regular, like your stomach is like doing regularly, and then maybe you can see doctor. Any suggestion about it?
So that's a good question. So I think your question is essentially, what are the early symptoms of colon cancer? So
yes,
screening, when we do screening for colon cancer, ideally we want to find that colon cancer before there's any symptoms. And so when I showed you it crosses that line, that means it's become technically a cancer, but even at that early stage, you will have no symptoms at all, because it's such an early stage. It just barely crossed that line. Even it crossed that line and goes, so the way we stage colon cancer, in the wall of the colon, there's layers. And the deeper it invades in those layers, the more advanced that colon cancer is. And then eventually it will spread. So we want to find it before it spreads, of course, but we want to find it even before it invades into those deeper layers. And so when it started to invade those very superficial layers, usually there's no symptoms. And so that's why screening is the best test, because it will be able to find and identify the cancer before it has any symptoms at all, at a very early stage. If it becomes a little bit more advanced, the early signs of colon cancer that you can look for would be things like blood in the stool. Sometimes that's hard to appreciate because, let me see if I can pull up the slides again. Just it'll be easier to see with a picture. Here we go. So here, so when I say you can look for blood in your stool, that's good, but that's really mostly going to be helpful if the cancer is here, right? Down here in this part. If the cancer is here on this part, then the stool still has to go all through here, down here, across here. By that time, that blood, that red blood, is already digested by the GI tract, by the system. So it doesn't look red anymore, but you can still identify it. It's called, we call it melena. It's dark and tarry stools. So when blood gets digested by this colon and it comes out, if it's digested blood, then it looks very dark, like Like if you've ever seen them pour tar on a fresh, when they're doing the street, you know, that really dark, you know, heavy black tar, that's what it would look like. So if you see that, that's concerning, that there is some bleeding happening somewhere in your GI system. We don't know for sure. If you see that, we don't know where it's coming from. It could be coming from here or here or here, maybe even the small intestine, or maybe even the stomach, right? Because it's all part of the same system. But that's something that you should bring to the attention of your physician. If the bleeding is coming from here, this end part, then oftentimes you might see red blood. And then still that should be brought to the attention of your physician. Other things that are relatively early would be something like any change in your bowel habits. Like if you're normally very regular and you go, you know, you have your own schedule and it's the same way every day, every time, if there's some disruption in that, then pay attention. That doesn't mean you have to go, you know, first thing your mind should go to is cancer. Sometimes you can have, you know, life stress or change in your eating habits or whatever that will cause some temporary, you know, change. But if it's persistent, then pay attention to that. The other thing that you can pay attention to is they talk about change in your stool caliber. That means, I mean, not to get too technical, but if it's normally a very large caliber stool, if it starts to become what they call pencil thin and very thin, then you have to worry that why is it becoming so thin? Sometimes if there is a cancer or a tumor sitting here that is taking up 50%, let's say it's taking up 50% of this space, then the stool that comes out is going to be thinner, right? And so if you start to see that, then, you know, bring it to your physician's attention. And most likely they'll start with, you know, a colonoscopy. You know, if blood is not normal really in your stools at any time. And so that should always be brought to the attention of your physician. And you know, we're taught, you know, very early on that, you know, rectal bleeding is cancer until proven otherwise, you know, because you don't want to, that's the one thing you don't want to miss.
Yeah, that's why I want to know about this thing, because this is the thing we can pay attention and then see what is happening. You remind me on those days, like when I was in school, because you are very young and then you are scared of everything. And before exams, I always have my stomach like, okay, kind of diarrhea thing. So on that I can recall it. It's stress, something, you know, it's not the every time is something like you are sick, but again, paying attention is a more thing. Thank you very much. And I was listening what that you mentioned about the tanning beds, because light skin people, they like to have little bit tan skin tone. So yeah, that's a good point. Actually, you mentioned about that, like tanning beds are not good. And thank you very much. I think we cover so many things in that. And if you can share, we can share your email address. Actually, is it okay to share your email address
Yeah,
so
sure.
people can
Absolutely. Within the
email
group,
you? Okay.
please feel free to share my email address and reach out to me with any questions. I'll leave my email address here in the chat box.
Okay, that's awesome. And then this is almost time, so perfect timing. I didn't see any more question on that one. If you have any questions, you can email to Gautam. He is providing the email address, or you can talk to us in case you missed that, so we can help you to reach out to him. And whenever we talk about health, we are talking about like healthy habits. We talk about the alcohol, smoking, healthy habits, exercise, again, yoga, meditation. That is the more beneficial things for your body and for your mind. And then again, happy life also, because whenever you're happy, whenever you are stress-free, then there are some chemicals get released in your body. I don't know the name because I'm not the medical person, but yes, but I learned about it one, like, yeah, that make your body and mind stress-free, and then you are physically better than before. So just go with the let it go attitude. Don't stick with the hard things with you, because it's a time. You say time never stops. It's going away. So things are also like, don't carry your past, which is bothering you. Just let it go to free yourself, to make yourself happy. So when you're happy, your body reacts inside and then release those all chemicals. Those are good for your body and for your mind. So that is a good recommendation. And you can come to the yoga center. We do satsang every Sunday, yoga meditation. And tomorrow, actually, we are celebrating Janmashtami there. So it's a little bit like skit, and then the people who volunteer there, they arrange a little bit dance program, Bollywood dancing or traditional dancing, and then a skit. So they work hard on that one. Come and see. We are tuning from 4 p.m. to 6:30 p.m. And that includes dinner also. Baiji is making the dinner with all the blessings. So please come over. It's always good to get out and have a good company and enjoy something for your good body and your mind. And I want to mention about another next Jivanta. Next Jivanta, we are meeting at September 24th. And again, we are including I am is the highest form of meditation by Naresh Pathak. You heard him before, Dr. Naresh Pathak, and he's going to talk about the I am is the highest form of meditation. Who I am, medically, spiritually, everywhere. So you have to work on that one and keep working on that, joining Jivanta every month. And thank you very much, Gautam, for spending your time for this seminar. Thank you very much, Jignaven and Baiji, both Baiji, that you give us the opportunity and you give us the right path to work on that one. Thank you very much for joining, everybody. And I will conclude. The Baijis are there. Yes, Baiji. Jai Sachidanand, Baiji.
Yes, Sachidanand. Thank you.
Thank you, everyone.
Thank you, Gautam.
Okay.
Thank you so much. We really appreciate you.
Thank you, Baiti.
Even though you are busy schedule, you are giving us time. Thank you so much.
Of course, anytime.
Thank you, Gautam.
Thank you, Gautam. Very nice session. We learned a lot today, and hopefully we can watch out for ourselves and bring some more questions to you when we get to see you in person.
And we're going to conclude the session. I think
Thank
somebody else wants to say something. Taraben. You have to unmute yourself.